NATO's medical response is a military medicine center of excellence from Budapest. So now we will discuss steps they have taken in the response to the current crisis, as well as the lessons they have learned and recommendations for the future. Our guest speaker is Jack Taylor. Jack is a Navy surgeon currently stationed at the NATO Center of Excellence for Military Medicine in Budapest, Hungary. He is board certified in both general and plastic surgery. He was deployed as the executive officer for the NATO Role-Free Multinational Medical Unit in Kandahar, Afghanistan. It's a pleasure to have you, Jack, here with us. So the floor is yours.
Thank you. Good morning. I would like to, as you noted, I would like to discuss what the MILMED COE has done so far, but I'd like to do that in the context of the crisis itself. So I'm going to give a little background and a little timeline as to the COVID crisis. In December, the World Health Organization detected a cluster of pneumonia cases in Wuhan, China through its epidemic intelligence system. 3 days later, in face-to-face meetings in China, the reports of a new virus were confirmed. The World Health Organization monitored the situation, and as the number of cases grew, it met frequently to discuss the public health significance. On January 30th, 2020, a public health emergency of international concern was declared. A PHEC is declared when the World Health Organization determines that a public health event constitutes a public health risk to other states through international spread of disease and will potentially require a coordinated international response. Temporary recommendations, including health measures, are made to the state party experiencing the PHEC to prevent or reduce the international spread of disease and to avoid unnecessary interference with international traffic. While some states undertook measures to limit the spread of disease, it was not until, and we've heard this often today, March of 2020, that most countries declared a state of emergency. The MILMED COE, and specifically the Force Health Protection Branch under the guidance of Lieutenant Colonel Silka Rule, recognized the potential for a serious health emergency prior to the World Health Organization declaration and began publishing updates on the COVID virus. The first update was published January 23rd and was a 2-page information sheet and gave information specifically about the virus and potential mechanisms to prevent spread. The Force Health Protection Branch now produces 2 different updates each week. One is a shorter update, and the second is a longer, approximately 26 pages, that includes many of the national policies, including mitigation of disease spread and roadmaps for de-escalation of social isolation policies. You can find copies of this on our website, and there is an email address for the Force Health Protection Branch, in which you can contact them if you're interested in getting this information. On March 7th, the COE organized a COVID working group. This group is responsible for coordination of activities related to the COVID crisis within our COE. Among its responsibilities, it organizes a weekly multinational VTC to discuss national concerns and to share information. I will discuss more about this in detail later. The working group also coordinates the lessons learned process for the COVID crisis, sharing notes from the conferences and relevant medical literature. They've also developed on our website a specific area devoted to the COVID crisis for the sharing of information and where you can find all of our updates. On April 7th, the COE began assisting the Committee of the Chairman of Medical Services, or COMEDS, with the development of a questionnaire to be sent to the Surgeon Generals of the Alliance and partner nations. The purpose of the questionnaire was to understand where the national policies differed and what problems each nation was faced in dealing with the crisis. It focused on what nations were doing in the areas of diagnosis, mitigation, treatment, reintegration, de-escalation, and what role did the nations see for NATO in this crisis. The goal was to develop a coherent plan for dealing with biothreats and learn from the challenges currently being faced. The most significant project by the COE has been the weekly Force Health Protection VTC. This has been conducted now 5 times and is attended by national representatives from each of our nations and from NATO command representatives. The VTC gives the nations an opportunity to share what they are doing in real time and ask for advice for challenges that they have encountered. It also gives the ACO, ACT, and IMS medical advisors a forum to disseminate new information and policies. You can see some of the topics that have been discussed. The first VTC was just specifically on general information regarding the COVID virus. On the second, we focused on testing, and it was very clear from this VTC that testing was an issue for most countries. We have limited testing opportunities at the moment, relying primarily on reverse transcriptase polymerase chain reaction. And antigen testing is underway right now to help with a faster method of testing. The second VTC focused on air medical evacuation, which is an issue for most countries. The fourth was on de-escalation strategies. And yesterday, the fifth VTC was held and discussed collateral damage, including mental health issues related to the COVID virus. Since this audience is from many backgrounds, I'd like to share a little bit about the virus. Because I think there are some misconceptions that are out and certainly spread within the media. The coronavirus is not new. It is the same virus family which caused SARS in the early 2000s, MERS in the mid-2000s. The virus was initially identified in chickens as a respiratory virus in the 1930s. But has undergone many genetic mutations since then. It is known to be a zoonotic disease, meaning one that is found in animals, but can now be spread to humans. Experts have warned about this virus and its potential for causing a pandemic as early as 2007. This is, and there are many examples in the literature of articles such as this. But I find this one to be one that is the most telling about what we could have done to help at least mitigate some of the problems we're facing today. This is an article from the Clinical Microbiology Reviews of October of 2007. The authors note that SARS could return if conditions are fit for introduction, mutation, amplification, and transmission of the dangerous virus. The authors further state that gaps exist in terms of what we understand from a molecular basis of the virus, its physical stability, and its transmissibility. They also note that we know very little about the pathogenesis in humans, that we have very poor screening tools for detecting the virus, that we have no foolproof infection control procedures for patient care, and that antivirals for treatment are lacking, as well as a vaccine is lacking. Specifically, the last part of this article, should we be ready for the reemergence of SARS? And they note that coronaviruses are well known to undergo genetic recombination, leading to new genotypes and outbreaks. They have a reservoir in bats, which are consumed in China. And as they point out, is it the possibility of reemergence of SARS is a time bomb, and we should not ignore the need for preparedness. So what do we know now? After 4 months, we have shown that we are unprepared for a pandemic of this type. Our levels of personal protective equipment for a pandemic are insufficient. We do not have the stockpiles necessary of masks, gowns, and gloves. Our supply chains for the production of this equipment is vulnerable. With a limited number of suppliers, we're at risk if the suppliers are unable to continue production due to their own fight against a biothreat or a scaling back of production to gain a strategic advantage. We also have a shortage of medical equipment such as ventilators and certain medications. Again, with a limited number of companies producing these items, we remain vulnerable if there is a dramatic increase in need. Due either to a lack of planning or disregard from the advice of our experts, we are unable to accomplish the most basic epidemiologic control measures, including testing and contact tracing. This one measure may have significantly limited the spread of disease, or at least limited the extent of social distancing necessary. We have not identified any effective treatment for this virus, nor has there been any work done on vaccine development prior to the recent outbreak. Currently, the best estimates are that a vaccine will take 12 to 18 months for development. The questionnaire that I mentioned earlier that was distributed by COMEDS has also revealed several areas in which there are no standardized protocols between nations. Social distancing and mask use has been implemented with different requirements at different times. Testing and quarantine protocols differ between nations. Nations have differed in their approach to testing medications and clinical trials for the treatment of COVID. Nations are still developing plans for de-escalation and of de-escalation measures. Most significantly, nations have varied in how they have used the military to support civilian efforts. To date, NATO's role in the current crisis remains unclear. Several implications for these findings can be seen. Article 3 of the NATO treaty requires parties to the treaty to maintain and develop their individual and collective capacity to resist armed attack. NATO has further defined this requirement as a need to be resilient, to resist and to recover from a major shock, such as a natural disaster, failure of critical infrastructure, or a hybrid or armed attack. In 2016, at the Warsaw Summit, 7 baseline requirements for national resilience against which nations can measure their level of preparedness were identified. These included continuity of government and critical government services, resilient energy supplies, ability to deal with uncontrolled movement of people, resilient food and water resources, resilient civil communication systems, resilient transportation systems, and ability to deal with mass casualties, ensuring that civilian healthcare systems can cope and that sufficient medical supplies are stocked and secure. It is this last item that we must address as we recover and learn from the COVID crisis. The COE, in response to the information gathered from our VTCs through literature review and through the aforementioned questionnaire from COMEDS, has developed several areas in which we will progress with development of new projects for the COE. One is development of a more robust medical intelligence capability. We need a faster and better mechanism for biosurveillance, mitigation, and recovery. Most of this can be done in the context of the global health security agenda and with the World Health Organization, but we need closer ties with them so that our nations are able to respond faster when a public health emergency is declared. We must address the supply chain vulnerability. As we heard earlier from the European Disaster Response Committee, that stockpiling is one of the areas that they will address. However, this needs to be done rapidly. We also need mechanisms for sharing among partner nations. When one nation is overwhelmed and one is less affected, being able to share supplies. We should also be looking at how technology will allow us to mitigate some of these problems, including the use of technologies such as 3D printing. we should be training now non-medical military personnel to do certain things such as testing, contact tracing, and medical administration. If we do this within the context of the military, then it can spread to the civilian sector as well, and we will have a population of people who are able to rapidly start testing and contact tracing. We should focus more on the use of virtual medicine and telehealth. The MILMED COE is already in the process of developing new training programs for the use of these technologies, and we need to update our outbreak-related courses. It is unlikely that this is the last time we will face a biothreat of international significance. We owe it to our nations and to our nation's citizens to be better prepared in the future. Thank you.
Jack, thank you very much for this very comprehensive presentation. It's put a light on us from the specific medical point of view. Let me ask you maybe just one question.
Yes.
Do you think that we can get quite soon a reliable test which we can done at our home? I mean, we can test ourselves. Do you think that is possible?
So there are several hundred companies right now that are in the process of developing tests, including what I assume you're referring to, antibody tests, so we can tell if we have been infected or not. I think that those are coming, but they are still several months away. Whether we can do that at home or not, I'm not sure. But I know that there are companies that are testing exactly that, self-testing options.
Yeah, for sure. It seems that somebody would like to make a business on that. This is no doubt.
Yes, I'm sure that somebody could become quite wealthy in a business like that.
Okay, thank you very much, Jack, for your intervention. Thank you for all panelists of the second panel. And right now we are moving to the next stage.